What is the role of genetics in precision medicine of tumors?
The concept, the general concept of precision medicine, at least for me, is the concept of a sort of magic box in which you need to have one or more genomic alterations, you need to have one or more diagnostic assays, and you need to have one or more therapeutic agents. When you have these three components, usually you are implementing the concept of precision medicine. You can use this kind of tool of exercise, if you want. And you see that when you are talking about cytotoxic chemotherapy, you can have a target, but you don't have a diagnostic assay because target is DNA for most of the cytotoxic agents. Not only DNA, but for most of them is DNA. But you don't have a selective target because chemotherapy by definition is not selective. It's a matter of fact that you have side effects on normal tissues and you have side effects for the patient. So this is an evolving concept. It's something that we are still at the beginning, in the pediatric era of precision medicine, in the early days. And consequently, we have an incomplete landscape of the potential of precision medicine for human beings.
Is precision medicine changing the planning of the trials?
Well, it's a matter of fact that dealing with multiple molecular alteration in the context of one specific type of tumor, and I'm referring, for instance, to adenocarcinoma in lung cancer, or to melanoma, or to squamous cell carcinoma of the lung, or whatever you want in terms of morphological diagnosis, you have a set of genomic changes. Some of them are already druggable, others are not. But when they are potentially druggables, you don't need to investigate one genomic change at time, every time, but you can collect all these genomic changes in the context of one specific study design. And there are, in principle, two study designs that we are exploring these days. One is what we call an umbrella study, the other is the basket study. The first one is looking to one type of tumor with multiple molecular alteration. You are testing the specific molecular approaches based on the detection of the specific molecular alteration. The other one is to start with one molecular alteration that you have seen in multiple tumors. This is not able to guarantee you that the role of one specific alteration, the context, the histological context is the same across different type of tumors. For instance, KRAS mutation in colorectal cancer, KRAS mutation in lung cancer. But it's a matter of fact that you are starting with one or two molecular alteration, and you are exploring the role of this molecular alteration across different tumor types. And that is what you call, or we can call, basket study. What is the beauty? You are minimizing the potential for a failure rate, because if you are investigating one target, it could be that it's not the right one, and you are leaving behind the others. Investigating the overall landscape is much better because it's minimizing your risk. At the same time, you have a sort of good explanation. You have a good appeal for the patients because you are explaining to the patients that they are part of a sort of genomic enterprise to improve the quality, the survival expectation of other patients.
Grazie mille. Ne avrei altre 3 o 4, ma non ho